Hey, this is Elliot Fishman. Welcome to our Facebook Live. Sorry, we moved it from 12 to 1, but I had a meeting that came up and I couldn't get out of. So I just wanted to welcome everybody. Just a few things. One is, under the announcements, our next Incredible CT meeting is beginning next Thursday. Actually, Thursday, you have to get there. Friday, Saturday, Sunday in Nashville at the Gaylord Hotel. Should be an excellent meeting in an excellent city. We have excellent speakers. We have the Hopkins riffraff, plus including myself. Plus we have Jeff Rubin from Duke and Charlie White from Maryland. So I think it's really a terrific meeting. Excellent lectures. We have hands-on workstation training. If you want to learn how to do cinematic rendering, Tony Cook is an expert and he's doing the training. And anything you want to do on computers, we'll be able to show you. So it's a great meeting, a great rate, a great hotel. And hopefully we'll see you there. Let me just, I'm going to speak about vascular today, but let me just tell you a little something else. So last night I went to dinner, and today I went to grand rounds at Hopkins in surgery. And it's the John Cameron annual lecture, and that's a very, very honored lecture. Dr. Cameron is still going strong, on the way to Russia tomorrow, actually. But the lecture, Dr. Cameron was chairman for about 17 years at Hopkins. I know from the talk today that 41 major chairs in the United States in surgery were direct trainees of his, which is indeed a record that's even more than Joe DiMaggio's 56-game consecutive streak that nobody will ever reach. And the speaker was Keith Lillimo. Keith Lillimo is a god. I remember Keith Lillimo. We both came up the system together. Keith was in surgery, of course. I was in radiology. Keith is what the best and the brightest that Hopkins or anybody else can do. Keith was an incredible surgeon and is an incredible surgeon, particularly in pancreas, but he can operate on anything, anywhere, anytime. God forbid someone in your family needed surgery, you sent them to Keith. Keith won the teaching award like 5 years in a row, which is unbelievable. Keith did really significant research and still does research. Keith is now, and for the past 8 years, has been the chair at Mass General Hospital. So 28 years or 29 years, he said, at Hopkins, 8 years at Mass General. And he's really changed the Mass General program for the positive. He gave a talk today about the similarities between Mass General and Johns Hopkins Hospital. It was amazing, the similarities. Mass General started earlier, however, but just the amount of incredible people that both of those places developed, the number of incredible people that came from Hopkins and landed at Mass General, including Keith, the number of incredible people from Mass General who came to Hopkins. And so this kind of mix of incredible people. The other thing is, I will say, there's something about surgery. Now, I'm an outsider in surgery, and they had dinner last night from the chairman to John Cameron to Keith, and all the faculty were there, probably about 25 people. There were two people who were outsiders, Ralph Ruban, who's head of pathology, and me. And I've always taken that as the highest honor. And when Keith spoke today, he mentioned both Ralph and I as two key people in his development and just in general in pancreatic imaging. And that sounds like an ego trip for me, and it probably is. But at the end of the day, when you have someone like Keith Lillimo recognizing you, it really says that working hard and working and trying is really worthwhile, because those 10 seconds of someone calling you out is something that you always do remember. So Keith was here, Keith is going back, and Keith was many of the incredible people. He mentioned the people of Bear Zinner and who was there, and then of course the people who John Cameron trained, like Jeff Drebbins, head at Memorial Sloan Kettering, and Charlie O at Jefferson. And it goes on and on. Rick Schulich in Colorado, and Selman Vickers, who's now the dean down south. So just an incredible talk he gave. and it was really good to see him. I do remember way back when, and I said it last night when Dr. Cameron asked me to speak about a patient we did together, and I won't mention the patient's name, though it was in the newspapers here, when it came out. It was a patient who was a baseball player who had something wrong, and they thought it was diverticulitis. And the patient was in their 30s, so you expect something inflammatory. He didn't do well. He wasn't doing well. He signed out from a great medical center across town, brought the CTs over. We looked at them, and we thought it was a colon cancer. He was operated on successfully. He did great. And Keith is a major sports fan. And when the player returned, Keith was in the dugout. Keith was on ESPN. And they said, "Thank you, Johns Hopkins," on the thing. Now, they didn't invite me. I was a radiologist. We didn't get to go to the game. I saw it in the newspaper. I heard the stories. But no one deserved that more than Keith. And Keith did say that he, though he's in Boston, which is a great sports city, he's still a Raven fan and an Oriole fan. But he loves the Bruins and he loves the Celtics, even though the Celtics just got destroyed and kicked out of the playoffs, losing 4-1. So they weren't too pleased about that. But it's really good to see people and people who've just done incredible. And it really kind of inspires you to work hard and do great things. So that's sort of background, and I could go on and on about that. But I'm supposed to talk to you about vascular today. So I did want to speak, and I'll just tell you that I was just finishing up a series of lectures for CTisus, and over the next 3 or 4 months, you're going to get about 6 lectures on vascular, abdominal aorta, pre and post-op, and some of the vascular things like SMA syndrome, median awkward ligament syndrome, and all sorts of different things. And I think one of the big things of CT with fast scanners, with dual energy, with cinematic rendering, with volume rendering, is vascular imaging. And vascular imaging is really, really a key part of CT. Now remember, we do make the point that every case we do is vascular imaging. Every pancreatic case we're doing the celiac and the SMA and the hepatic artery. And every liver case we're doing the hepatic artery and the branches. And every renal case we're doing the renal arteries and the aorta and the IVC. And yes, we do a lot of vascular cases. We do TAVRs. We're evaluating the aorta. We're looking at the aortic valve. We're looking at the aortic size, looking for areas of stenosis, looking for vascular approaches. We have an older population, so we're looking at abdominal aortic aneurysms. We're looking at thoracic aortic aneurysms. We're looking for change. We're looking for surgical planning. Do we need to do open surgery, or can we do endovascular stents? The placement of endovascular stents, the placement of TAVRs, for aortic valve, are all things that are really changing the face of surgery, changing the face of how we treat patients, and we're getting better outcomes at lower costs with less morbidity and less mortality. So from a radiology perspective, there's several things you really need to do, and that's what I was going to talk about today. And maybe I'll just focus on protocols and post-processing, and we can go back into more specifics at a later date. Perhaps I should wait for my lectures to come out. Then if you have any specific questions, that would make it a little bit easier. So let's talk about what do we need to do. When we do vascular imaging, we always give water as an oral contrast agent, 1,000 cc's. Several things happen. 1, you distend the bowel and stomach. You get rid of a lot of pseudotumors. 2, you hydrate the patient. And so there's less chance of contrast nephropathy long term. And you distend the bladder because if patients get a lot of water, they urinate, and then the bladder fills with urine. And then you can pick up small bladder cancers, which are not uncommon and easy to pick up. So you get a lot of extra information for free. Now, we then talk about injection rates. 4 to 5 cc's a second is ideal. We use either Omni 350 or Visi 320, depending on the patient's creatinine levels. We use 100 to 120 cc's of contrast, depending on patient size. We typically almost never use above 120. We don't use 150. Some people use low contrast if patients have issues with GFR or creatinine levels. If you have dual energy, you can, particularly on runoffs, use a lower dose of contrast, lower volume that is, and then use dual energy to optimize the visualization of the vessels. So those things are all possible. So we acquire the data with thin sections and thick sections, ideally 0.75 by 0.5. And then we do threes. The threes probably are most helpful for being able to look at the overview of the entire chest and abdomen, or just the abdomen and pelvis, depending how the scanning is being done. When we do the post-processing, we do volume rendering, we do MIP, we do multiplanar. So you need to look at each vessel at its origin, whether it's the vessels off the arch, the carotid, subclavian, and the like. You need to look at the origin of the celiac and the SMA, look at the branching, you look at the renal arteries. Particularly in older patients, there's a lot of different disease processes. We see aneurysms incidentally, splenic artery number 1, sometimes renal arteries, sometimes hepatic arteries. Again, any artery can have a problem. We talk also about, and I won't go into this talk, we talk about vascular, we think of atherosclerotic disease, that's what I'm referring to, but we do vascular in different syndromes, like Marfan syndrome, dilated aortic group, tulip-shaped configuration, dural ectasia, possible dissection. We talk about the Loeys-Dietz, aneurysms, dissections, very tortuous vessels, younger patient, something we need to look at. We talk about things like Ehlers-Danlos, focal aneurysms, often multiple, often in strange places. The vessels have a weakness in the wall and they kind of focally bulge. So we talk about looking at those patients as well. We talk about the importance of being very careful when you're looking, not just looking at the aorta, but looking at the branch vessels. Things like MIP imaging make it much easier to look at the mesenteric vessels, which is critical. You don't only want to be looking at the big vessels, you have to look at the small vessels as well. So that becomes very, very important. We also then talk about the post-processing. I think it's critical. Axial imaging for looking at vessels is very limited. I think MIP works very well, particularly when there's little calcification present, and it depends what you look at. But in terms of a global perspective, volume rendering is ideal. Cinematic rendering, which is a form of volume rendering, can be spectacular in many cases. And you need to do that routinely. You need to create the images referring the physician wants. I'm meeting today with Jim Black, who's head of vascular surgery at Hopkins, and he basically prescribes to us what information he needs, and we need to be able to provide that information for him. So that becomes very critical. In terms of apps, I mentioned atherosclerotic disease, but I also should mention we do a lot of vascular imaging in trauma, your typical gunshot wound, stab wound, you're looking for vessel injury, you're looking for spasm in vessels, you're looking for dissection of vessels, you're looking for active bleed, you're looking for associated injury to muscle and soft tissue. Doing all of those things. And again, the protocols, you want to have them set very well. Remember, these are ER patients. The patients are often unstable. Of course, in those cases where we're looking at vascular injury and trauma, we're also looking at the key organs, be it liver or spleen or kidneys, bowel, and the like. So it really becomes multiple components to a single examination. Now, one thing I should say as we're getting near the end, perhaps, so if people have any questions, I see Lidiana's here. And Lidiana, how you doing? And Lidiana's in Palo Alto, great place to be. And Mahir is in Paris, and Henry is in Hong Kong, or he's from Hong Kong. Is the Aquilian one? Aquilian one is a good scanner, and yeah, does good vascular imaging. I think for most part, if you have 64 slice or better, you can do good vascular imaging, as long as you do good timing, good injection rates. Obviously, the faster your scanner is, the better the spatial resolution, the better you get good detailed vascular maps. But I think once you reach 64 slice, everything you need to do, you should be able to do. Now, Chris wants to know, do you perform single phase or multi-phase scans? Hello from St. Lucia. That's a good place to be. It depends on the scenario. If we're doing a patient with an endovascular stent in place already, kind of a follow-up, we do non-contrast, arterial, and delayed. This way we can look at the best look for endoleak. If we're doing a patient where it's rule out dissection or a follow-up dissection, a follow-up aneurysm perhaps, then we'll do single phase in most cases, just do an arterial phase, usually about 30 seconds, and then be able to match what we see. If you see something funny on the arterial phase, you always could go back and get venous phase. I don't think for things like rule out dissection, you need 2 phases. And I don't think you need non-contrast. Now, some people for chest will say to do non-contrast because you might miss an intramural hematoma. I think most of the time, I think almost always, you can see it on the contrast scan, though it may be harder to see. Sometimes intramural hematomas, particularly when they're really thin, become very hard to see on the arterial phase, but are much better to see on the later phase. High pitch, I like high pitch. You want to scan as quickly as possible. The spatial resolution is good enough. You really want to scan, and the timing is critical because you want the entire aorta to be well opacified. When you do runoff studies, you need to be careful because often with runoff studies, particularly as you get near and beneath the knee, often you can be too early. So you need to be very careful in that regard. We do some timing, we do triggering off certain trigger points, and you want to pick the trigger point and the timing in the area closest to where you need to be. So that can be kind of challenging. What are the risk of injecting through an IJ, PICC line, or portocath? I think the answer is always the same. If you're going to use a central line, some sort of line, it needs to be CT rated. There are IJ lines, there are PICC lines, there are portocaths that are made and designed for CT scanning. Most of them say CT usable or CT, something with CT on them. They always list a maximum injection rate. So I think you need to be very careful. Someone just has a line and you don't know what it is, you start injecting. That's like a recipe for a catastrophe. We don't do that. We need to know what's in there. And we've pushed people now, when you're putting central lines in, make sure a lot of the lines are that we're able to inject from. And there are a number of different companies that make lines. Becton Dickinson is the one we use for most of our lines, but there are a number of other good companies as well. And we don't have any stake in Becton Dickinson or anybody else. So that's not like we're getting given a dozen candy bars or something like that by Hershey's for saying that Hershey's is very good, which I would say for a dozen candy bars. I probably would say that for 6 candy bars. 2 candy bars, I probably would say that. Let's see what else. If anyone has any last minute questions, I guess we'll be back here, I think, next Wednesday because I'm going to be in Nashville on Thursday. I'm going to the RCA tours. You get this tour and you go to this place where this building where they made 650 number 1 records and where Elvis did his piano playing. Okay, so that'll be kind of cool. And then we're going to go to the Country Museum Hall of Fame. Super cool. And then we're going to, not to the Grand Ole Opry, but to the place that was the original Grand Ole Opry. And we're going to see some, I don't know who we're going to see. But it's not Kelly Musgraves, unfortunately. She's not going to be in town. I did call her. She said she would like to be there. She'd like to come to the meeting, perhaps learn a few things here and there, but she's not going to be able to do it. So we'll have to just watch her on YouTube or at the bars. Not that I go to bars, but in Nashville is the only place in the world the Starbucks has someone playing guitar and singing. When you go to the airport, all the little lounges have people playing guitar and singing. You go to the bathroom, there's somebody playing guitar. That part's not true, I don't think. But the rest is all true. You have to take my word on it. Anyway, let me see any other questions. Kieran, any effective eye dose during CTA? I think the eye dose is good. Anything that lowers the dose. I think with CTA, you can lower the dose and still get really good studies. So I think that's very important. We are seeing a lot of upper extremities. Kalina Davis makes that point. We see lots of trauma, Baltimore stab wounds. Bone removal, dual energy works really well in upper extremity trauma. And I think that probably is my time. And those are the questions I got. So we'll see you next week. Just to let you know, go to CTisus. Our page on AI is incredible. A lot of the Lustgarten stuff, a lot of the key articles that are coming out. Just amazing how fast that site changes week to week. And also Count Me In is there. And it's right beneath the AI, Count Me In. Just incredible the work they're doing. And a lot of information for Count Me In is online now. We connect up to their site. So with that, I thank everybody for their attention. And we'll see you next time.